So welcome everybody, my name is Magali De Castro. I am the Practice Support Officer here at Bayside Medicare Local. I also look after the chronic disease team. So triage and infection control. We're going to cover a lot of things today. This is going to be very much your everyday type of stuff. So a lot of these things you will know, and a lot of these things I'll ask you to tell me how you feel you're doing in your clinics. Let's get started. Today what we're going to talk about is obviously triage and infection control, but I want to make sure that we start by looking at the accreditation standards as they relate to triage and infection control. Why would we want to look at the accreditation standards?
You have to abide by that.
You have to abide by that? That's a good point. Do we have to? Is accreditation mandatory?
No.
It's not. It's a voluntary process, but what's the advantage of doing accreditation or going through the accreditation process?
You know you're up to the standard.
Funding, yes, so there's some financial benefits that the practice can access if they're accredited. What else?
Best practice.
Best practice. So it ensures that we're practicing to a level of best evidence, best available evidence. I will be going through a lot of resources here. The key resources, some of them are standard, are guidelines. So I'll talk about the RCGP guidelines and things like that. I will give you the links and show you where you can access those. But I'm also going to be covering some worksheets and staff training sheets that I've put together in the practices where I work, because my background is in general practice nursing and practice management. So you'll get access to those, but also, which means that I don't have to then put all of that information in your notes. You can access those electronically later on, and you can then modify them, put your practice logo in them, and they end up being a great resource for accreditation. The other thing that we're going to look at is we're going to have a look at what current processes and systems you've got at your clinic and how they're matching up to our accreditation requirements. And sometimes they will, sometimes they won't. I'm hoping most of us will. We'll look at triage, the theory and the practice of it. We'll look at infection control, some of the key policies, and a lot of the more frequently asked questions. And as I said, the key resources, guidelines, and tools. All right, so we'll get going. Accreditation. So what do we use? What's our guideline for accreditation? How do we know what we're going to be accredited against? The RCGP standards, which we're up to what edition now? Fourth edition. This is what it looks like. How do we get access to this?
Online.
It's online, so you can access it for free online through the RCGP website. But you can also order and pay for a paper copy, a hard copy. Okay. All of you have one of these in your clinics?
Yes.
Or have access to it? Good. Anyone first time you're seeing this resource, which is perfectly fine? Yep. Good. This is this is our gold standard for accreditation. All right, so let's get going. So the criterions that relate to triage, we've got criterion 1.1.1, and it's under the scheduling care in opening hours. So the key thing around this is, well, we have to make sure that our practice is a flexible system that enables us to accommodate patients' clinical needs. What does this mean? This is when we get to the actual indicators. So the indicators are the little ones that have A, B, C, so they're listed by letters. They either have a little triangle. They used to be flags, so we used to call them flagged indicators. Now it's a triangle, so it's a triangled indicator. When you see that little triangle, it means that it's a required indicator. If you do not meet that indicator, if you're not able to demonstrate that at accreditation time, you're not going to be able to meet that standard and therefore get accredited. So the first indicator says our practice can demonstrate we have a flexible system to determine the order in which patients are seen and to be able to accommodate patients' needs for urgent care, non-urgent care, complex care, planned chronic disease management, preventative health care, and longer consultations. Yeah, easy? Yeah? We're comfortable with what this means? What's one of the main things that we always get pulled up with accreditation around this? The longer consults. You have to make sure that your patients are aware that longer consults are available, yeah? And that you have to have usually signage or in your practice information sheet letting patients know that they should book for a long appointment if they've got multiple issues. Okay, that's pretty straightforward. Now this is when we get into the triage bit. Our practice can demonstrate how we identify, prioritize, and respond to life-threatening and urgent medical matters. So this is triage. Yeah? Now what systems do you have at the moment in your clinics? Just get some.
I'm telling you how not to do it, possibly.
Sorry?
How not to do it.
You've got examples of how not to do it?
Oh, a receptionist will come across a patient. The
Yep.
patient will say, I'm very ill, or is, anaphylactic, whatever.
Mhm.
Calls the nurse quickly, and the nurse comes.
Okay, so there's a system of, which is not the ideal system, of the receptionist will be there, the patient comes in, they're unwell, they go, I don't know, I'll just go get the nurse or the GP, or, yeah, which is what happens. How many people here, actually, how many people here are nurses? Yep. How many people here are admin staff? So either managers or, yep. How many of you have had actual formal triage training? Yeah, it doesn't really happen, yeah? We don't really get triage training as a regular thing. How many of you have a formal process in your practice to train new staff on what the triage policy and procedure is? Yeah? Do you think if you had started your work with a comprehensive training of this is the triage policy, this is how we allocate patients depending on urgency, these are the things that we would consider most urgent to least urgent, do you think that would have helped you in your positions? Yeah. So that's one of the things that we're going to be covering. So I'll show you the staff training sheets that I use in my clinics to train new staff on this is triage. Pretty important stuff, I think. Yeah.
We've actually got a flow chart on
Yeah.
reception wall, like the colour-coded flow chart.
Yeah.
I don't know that it's ever looked at, but it's there.
Yeah. Very good point. I don't know if it's ever looked at. Is it something like this? Yeah. We'll talk about this, yeah, in a little bit. All right. So let's keep going through our accreditation standards, because I just want to make sure that we get the not the legal, but the scary, what do we have to have out of the way first. Good. That's it for triage. That's the only indicator that's in there for triage. Yeah, that the practice can demonstrate that there's a system in place to prioritize. For infection control, it's a bit longer. So for infection control, obviously the idea is to prevent healthcare-associated infections. The main umbrella term of this is our practice as a system to minimize the risk of infections in a healthcare facility. First indicator, what did we say that the little triangle meant? It's required. We have to be able to demonstrate this. So our practice can identify the person with primary responsibility for coordinating infection control processes within our practice. And this person has those responsibilities defined in their position description. How many here actually have one designated person? Yeah, a couple of you. This is actually an accreditation requirement. So if it's not in place in your practice, this is something that we need to go back and look at. We need to designate one person. They don't have to be a clinical person, but it's the person who's going to be looking at the overall, has the overall responsibility to ensure all the infection control processes are adhered to and that we're reviewing them, and yeah. And that's in their job description. Another one, got a little triangle, so we have to be able to do this. Practice is a written, practice-specific policy that outlines our infection control processes. What do I mean by practice-specific policy?
It's to your.
It relates to,
your
yeah, it relates to our service. It's not just some generic template that I downloaded from the web, which is fine. There's nothing wrong with downloading the template. We have to customize it and tailor it to our clinic. Good. All good so far? Good. C, the practice team member. So remember this one delegated person, this one designated person for infection control, and the person with the delegated responsibility for sterilization process can describe in detail how sterile procedures are undertaken, including how we have access or provision of a good range of sterile equipment or disposable equipment. How many people in the room are doing sterilization on site? Yeah, quite a number of you. How many of you do sterilization off-site? Only 3 or 4 of you. Any of you use only disposable? Yep, 3. I would have thought that number was higher. Usually there's pros and cons to doing sterilization on site. The main thing in terms of accreditation is if you are doing sterilization on site, they will get you to walk them through exactly everything that you do. So from the pre-cleaning and the rinsing to the packaging to the checking, every single step needs to be spot on. In some of the clinics where I've worked, because we haven't really been doing, there's been a couple that haven't really done that many procedures, yeah? So they've decided it's actually a lot cheaper for us to only use disposable instruments, yeah? Because we're not having to then, it's the staff time looking after the sterilizer and doing the sterilizer, but the sterilizing, but then it's also the annual maintenance and the checks and all of this. And so it's a lot easier for some practices to just do disposable equipment. Now this person has to also be able to, as we said, describe the procedures. If you're doing them off-site, it has to be very clearly outlined what the process is, and the documentary evidence. At paper trail, you need to be able to track back. How can you make sure that this piece of equipment that I'm using has been sterilized and has been sterilized correctly? So not just because something went through the sterilizer doesn't mean that it's now sterile. A lot of things can go wrong in that process. We won't go too much into sterilizing, but I can towards the end because it's quite a specialty area. And safe storage, that's the other thing. Just because we sterilize our instruments, if we're not storing them and keeping them the right way, what can happen?
Damage.
Yeah, well, especially with the disposable ones, they expire.
Damage to the packaging.
Damage to the packaging happens a fair bit. Good. All right. D, we're still going. So see, remember we only had one indicator for triage? Infection control keeps going. All members of our practice team can demonstrate how we look at the risk of cross-infection, including things like hand hygiene, use of personal protective equipment, triaging of patients with potentially communicable diseases, and we'll talk about this in more detail. Safe storage and disposal of clinical waste. A lot of people don't think of clinical waste as falling under the infection control banner. Managing spills, and that's about it. The last one here is our practice is visibly clean, which I'm imagining most of us will be fine with that. And another one, practice team with delegated responsibility for the cleaning of the surgery or the center, can describe the process for the routine cleaning of all areas and can provide documentation on the practice cleaning policy. So all of you should have a cleaning policy. Most people will have one in their policy and procedure manual. How many of you have actually had a chat to the cleaners? How many of you actually have external cleaners that come in? Yeah, most. How many of you have ever met the cleaners? Oh, that's actually not so bad. Yeah, good. And how many of you have actually had an infection control discussion with you? Great, so that's at least 3. Yay, out of 50. That's not, yeah. Do you think there's potential risks there? Risks, yes. I mean, not risks for who? For us as the practice? For the cleaner? Yeah. Any risks for the practice? Potentially, if things aren't cleaned properly, if we don't know what they're using to clean things with. One of them is the your dirty, moldy mop, and you have no idea where it's being stored or what. What's the risk to the cleaner?
Sharps, possibly.
Sharps, yeah. Just exposure to contaminated waste, yeah. Good. So that's another area, and it keeps going. Okay, another one. The practice team member with the delegated responsibility for staff education on infection control. This will often be the same person that's the designated infection control person. Can describe what's the induction program. So how do we train new staff on infection control? Yeah. How do we teach them what our policies are, what we do, what's good enough, what's not good enough? Yeah. This is the other thing that I'll provide you with the staff training sheets. There's a template for that. And actually some of you already probably have it, no? Yeah. So there's actually a template for that, and the way that the sheets work, I'll show you in a little bit later, at the bottom it's got an area where the staff can sign once they've been trained on that, and that actually acts as a evidence of in-house CPD. So if you keep those for accreditation purposes, you're good. You can review them once a year, and there's many, many topics. Another one. Okay, this is another big one, is immunizations. I get asked a lot of questions around staff immunization. Do we have to immunize all our staff? Yes, no?
No, but you have to offer it.
You have to offer it. You don't have to have everybody immunized. Ideally, if we can, that's fantastic because we're reducing the potential spread of disease. But staff are able to refuse as long as you document that, what we need to have, and they always check. They will always check staff immunization records. Either people are up to date or they're refused immunization, that's fine as long as it's been offered and you've had that discussion. And that discussion can happen with one of the GPs, because that's confidential health information. So that's not just something to have, displayed for all other staff and everybody else to see. Okay? What are some of the immunizations that we would consider offering?
Peps, hepatitis.
So, Hep B, yeah, hepatitis B, flu, tetanus,
Whooping
possibly,
cough.
yeah. Whooping cough, yeah, pertussis, measles, yeah, MMR, those are our main ones. Good, and hope this is the last one. Our practice team can explain how patients are educated on respiratory etiquette. What do I mean by respiratory etiquette? Coughing technique, yeah.
Coughing,
So how are you currently educating your patients on coughing signs? Yeah, so having signs on the walls, yeah, or posters, even better, so they can actually see. Anything else? Anything that you're doing to help make it easier? Yeah, so having masks available, yeah. Hand gel, yes, for the patients or in the waiting room for them to use. And a lot of them will, if they see it, they'll use it. Yeah? And that all of that helps. The other thing is if you have tissues, have a bin near it. Otherwise they end up. Yeah? Good. Thank goodness. That's it. Those are our standards. Yeah? We haven't even gotten into the nitty-gritty yet. This is just what's required accreditation-wise. So the question is, what is expected to be provided free of charge, essentially, or the practice covering the cost for immunizations for the staff, and what's expected that the staff will pay for? Usually, there's no written thing that says this or it's one or the other. But the workplace, really, if the workplace is from an occupational health and safety point of view, if you're wanting to ensure that your staff is safe. And as a matter of obviously goodwill, it would be a good idea for the workplace to pay for the immunization. So be them flu or be them measles, like an MMR shot, or be it a Hep B. So really, yeah, a good solid workplace practice would be to offer the vaccine and cover the cost. But there's no written.
Implications if they did contract.
Potentially, that's a very good question. I'm not sure. I'm not aware of any legal cases, like any actual cases where it's happened, where because this is the scenario that you could have. The practice could offer the immunization. Say, are you immunized? Are you up to date? Well, it's going to cost you this much to have it.
In this case, they can refuse.
And the staff member can refuse. But then you could potentially, and this is one of those things that you don't know until it ends up in a court, and then that's when you have then evidence of, well, it's gone this way or it's gone that way, and it'll be a jury that will decide. If that staff member then contracts something, probably not flu, but it's probably something more like a Hep B or something like that, that could have been prevented with a vaccine, and the staff member says, well, look, the reason I didn't have it was because I couldn't afford it, even though I was offered, I couldn't afford it, that's why I refused. Potentially, and this is just a guess, because again, I don't have a clear case where this has happened, and we can look back, and potentially, yeah, the workplace could be liable. Yeah, they could possibly have a case, but there's nothing written that says that they have to or they don't have to. Yeah.
It should be, but
it's not must.
No,
yeah.
no.
And if it's a casual staff, you see them once in 2 weeks.
So yeah, so I guess it's that thing of it's risk management. So it's managing risk and making sure that you're providing your occupational health and safety wise. It's the responsibility of the workplace to ensure a safe environment for staff, patients, and visitors, whoever else comes through. So that's where, again, I can't give you a set yes or no. Yeah, there are companies. I think there are companies that actually one of the requirements to work in there is you actually have to pay for your own pre-employment health check. So it can go both ways. So yeah, but in that instance, they've made sure that this person hasn't started to work before, even if they're paying for it themselves, before that check or that safety thing has been put in place.
Part of that offering it to the staff, and they don't have it, but part of that would probably be under health and safety that they would explain the risks if they don't have it.
Yep, very much. So part of the comment was, if you're not going to, if the staff refuses the immunization, part of your documentation should be that the benefits or the risks, and both actually, have been explained to the staff member, going, this is why we're offering and recommending this, and if you're entitled to refuse, but this is the risk that then you're taking. Yeah, as long as that's documented, and yeah, that's fine. Yeah.
Surely it'd be different though if they're refusing it due to health issues.
Yeah,
For
again, it's
example,
not,
if
it's
you're
not,
allergic to egg white, you
yeah.
can't have a flu vaccine.
Yeah, if you have a contraindication, then that's again,
So
that's
it's not that you're
fine.
refusing because you're refusing because you don't want to get died.
There may be many, and there may be many reasons. There's many reasons why people might refuse. And again, it's not we're not gonna penalize, although some workplaces are doing this. We're not gonna penalize someone for refusing. It's just the process of documenting.
It's just acknowledging that they can't have it or
Exactly.
they won't have it, but
Yeah.
there's a reason why.
Yeah, but it also ensures that in the event of an
definitely.
outbreak, we have access to know who's protected, who's potentially not. Yeah, who's potentially vulnerable. So that's the other reason. Yeah. Anything else that came out? Or yep.
Is there no privacy issue with that?
Privacy issue. Yep. Very
I
good
know
point.
some of my staff feel very strongly that they don't
Yep.
want their health situation discussed with the accreditors.
Oh yeah. So in terms of privacy issue with the accreditors, what you like, with the surveyors, I should say, the people that are coming in for accreditation, it's more of what they need to check is that their staff, you could de-identify it or you could sort of block it if the staff are refusing. The process of accreditation though does mean that they have signed privacy and confidentiality agreements as well to participate or to be surveyors. But yes, certainly you're within.
I've always just thrown it back on them and said, you would need to speak with a particular staff person concerned.
Yeah.
Our general way of doing things is this,
Yeah.
but if you want access to a particular staff person's
Yeah.
record, you must speak with them.
And certainly what they're wanting, what they're more interested in is, are you checking? Are you offering the immunizations to your staff? Do you have a process of documenting? Yes, they're up to date or not, or they're refusing or whatever it is. Not so much, what about Jane? Is she,
yeah. To demonstrate it, you've always got to say what about Jane.
Yeah. So in that instance, what I could do, if I had a staff member who just didn't want to, you could de-identify the records and just show de-identified records, possibly. I haven't had that situation, but that's what it is, a tricky one.
No, they check the records every single.
Yeah, they do. But you haven't had a situation where you've brought this up. Like, this is something that I would bring up with ACPAL or GPA, so our two accrediting bodies. I would bring it up going, look, we have, again, what they're interested in is, do you have a system in place? Are you tracking it? Are you offering? Are you documenting?
Yes, sure.
Yeah.
They check everything.
Yeah, they do check, but this is a particular instance where I would take it back to them and say, look, I'm concerned about confidentiality of my staff. Also because a lot of the times the surveyors are their staff from
Yes.
other clinics,
Yes.
sometimes nearby
Yes.
clinics.
Yes.
Yeah.
Yes.
So there could be I
Exactly the
see
point.
see your
That
point.
is
Yeah, I
the
see your
reason.
point. And they may have worked with a person in the past, or they may they may have
Exactly.
children in the same school. Or there could be a myriad of reasons. So that's where I would take it back if you have that scenario. By and large, most practices will just show the records.
They share patients' files as well. And
Yeah.
just started as well, that's
Yeah. Yeah, because it also happens with the patient files when they're going through the patient records. So, yeah. But it's a good point, and it's something it's good to bring up and discuss. All right, let's just move on to triage. So triage, what is triage?
Prioritising patient.
Yeah. Then don't cheat. Then look at your notes.
No,
Yeah,
no,
it's
no.
prioritizing patients according to what?
Their urgent needs.
Yeah, how urgent their needs are. Good. So we've said, some of you have said that you've got different charts and things like that. How are you, where are these charts located?
By the reception telephone.
So some of you have them near the reception telephones, yep. Walls,
We have them in every office.
every office, yep. So that's another good thing. Every office, wherever there's a phone, wherever someone could pick up a call and a patient's there and they're saying, well, this is my situation, yep. So that way you have an easy reference. What else? Do any of you have them on your in your computer? So some practices, what they'll do is they'll have this chart start up, so open up with when the computer starts up. So if you turn it on in the morning, when you turn on the unit, it'll open up this file and they'll minimize it and keep it minimized on the desk throughout the day. And then if they need it, they just click on it and it'll bring it back up. Some people have tried to do it as we'll just make it the desktop of the, but then you have all the icons on top,
Yeah.
so then you can't really see. What is it that we need to
that's
move that
right.
icon, move that? No. So that's why if you just have it start up and then just click on it and it'll bring back up, that's just fine. What are some of the possible outcomes? So when we have someone, especially when someone rings in, patient rings in, what are some of the possible outcomes from that phone call?
What do you mean?
As in the result. What can happen out of the result of a phone call from a patient ringing in?
Having a heart attack.
Appointment.
It could be a call an ambulance situation, yeah. What else?
Call a doctor.
Send them to ED.
Send them to ED. So maybe who would we get to call an ambulance?
Chest pain.
So yeah, things like chest pain, yeah, things that we go,
Febrile.
this is probably going to need an ambulance.
Febrile convulsion.
Yeah, febrile convulsions possibly, yeah.
Seizures.
Anaphylaxis.
Seizures, anaphylaxis, things that we know they're going to need more comprehensive care or more intensive care than what we can give them here, and they're going to need it quickly. Yeah, so an ambulance is much better off going off there. There's no rule of thumb, there's no set rule as to the next question, but I'm just going to ask it anyway. Who should ring? Should you advise the patient to ring themselves, or should we ring on their behalf?
Depends who's there.
Depends, yeah,
They might
very
have a
good.
carer
So what
there
does it
with them.
depend on?
Like if they've got a carer with them who's calling,
So if they've got a carer, yeah, if they've got somebody there with them, I would get them to ring themselves, yeah.
if you don't trust that, you do it yourself.
If you don't trust that, you do it yourself. What are some of the disadvantages though, if we're doing it ourselves, if we're calling on their behalf?
You can't see what's happening, so you can't.
Can't
give
really
them
see
a-
what's happening, yeah.
You only have their proof of what you're saying.
Yep.
happened.
Yeah, you only have their word or whatever assessment you were able to make in that time. What else?
The ambulance, the person on the end can't speak to them.
Exactly. So the ambulance or whoever's talking you through it can't really then directly affect or advise the situation. Yeah. What else? We may not have their current address. So we might send the ambulance to the completely wrong address. Yeah. We may not have their current phone number. So their ambulance will often need a phone number to contact. So we might give them a wrong contact number.
But as a receptionist, you would check that while you're on the phone with the
Again,
patient.
yes, you would, possibly, but in an emergency, a lot of things can be missed, yeah? The other thing is sometimes they'll want to know what's the nearest cross street or what. We don't have that information because obviously we're not locals. A lot of the times patients will be ringing with the chest pain from their neighbor's house. So So they might pop down the, down the hallway and call you from there. So even though we have their current address, it's not where they are right now.
So generally when you're talking to someone on the phone, you get the basic information from them before ringing AAA.
Yeah.
Anyway, and if they're a current patient, generally just quickly bring up the file.
Yeah. The thing is, sometimes even with current patients, unless you're checking every single time, and you should check even during that phone call, that these are the current details and this is where you're at. And then one instruction would be good to give them as soon as you hang up the call with them.
I will call you back.
You could say you'll call them back. Say hang up the phone, leave the line clear. Make sure that you've got the phone number so that if the ambulance needs to get in contact with them, they haven't then started calling.
Contact them right at
Yeah.
this time, and three of you can talk.
Yeah, you can have like a three-way call. That would be ideal.
That's normal with ambulance actually.
Yeah, so that would be the ideal setup. We've had scenarios where the patient will ring and go, oh yeah, okay. They hang up and then they ring their daughter or they ring and so now the line is busy and you can't get through. Yeah, there was some.
As a receptionist or even as a practice nurse, I think really it's important to perhaps get the patient to speak to the doctor and authorize the call for the ambulance by the doctor, even get the doctor to speak to them obviously.
Yeah.
Because they can give them instructions obviously to ease the pain or.
So obviously this is a scenario if you're.
As a first call should act.
Yeah, but there's so many scenarios. It depends on your clinic. I can say one.
Does.
You try and get a hold of a doctor or nurse if you're talking to something that has such significant urgency. You're wasting time and the patient
Potentially,
what
yeah.
yeah.
Look, there's no one clear way of doing it, and that's where a lot of it is that on the spot judgment that you have to make. Yeah, and a lot of it comes with experience. Yeah, with confidence. One of the potential issues is if having reception staff who are really, really young, or fresh out of high school, or potentially still in high school, and they haven't had the life experience to make some of those, common sense, say calls, going, yeah, this is going to need this sort of help or that sort of help. But we'll get into more of that nitty-gritty stuff. So in terms of the outcomes of that phone call, we can have call 000, go to emergency department. Some people will refuse the ambulance. You had ambulance refusers, yeah? Go to emergency department. Okay, no, if it's not that type of urgent, it might be urgent enough that it needs to be squeezed in for an appointment today. So what kind of examples would you have in your clinics? Do you have a set policy of this type of patient or this type of presentation? We'll always try and fit in children. Yeah, sometimes falls in your clinic. Yeah.
Urinary tract infection.
Yes, that's another popular one. Yep, women with and anyone with a UTI, with a urinary tract infection. What else you said? Pregnant women. Yeah. And the other thing is obviously if it's not that urgent, it might be something that an appointment later in the week might be suitable. Sometimes they're just after phone advice and just a bit of reassurance that I'm not quite sure if I need to come in about this and okay, that's fine, I'll leave it. Yeah. Good. All right. So we talked about these wall charts. At the moment, it's being this particular one. There's many out there. This is one of my favorite ones. It was originally done by the Dandenong KC division. Now they're called SEPA, the Southeastern Health Providers Association. At the moment, if you go to the link, they're reviewing it, so you can't actually download the latest one. You've got my details though. This is the one that most of you would already have in your practices anyways. But if you don't have it, you can send me an email and I can send you the old, like the last one that I have. So I can send you, it's a Word document. So if you wanted to take it back and discuss with your GPs, because your GPs might decide, actually, for this condition, we would send them to hospital. We wouldn't want to see them here. Yeah? So they can move it around and they can modify that. Okay? The other thing is it comes with a set of what they call cards, which I can also send you, which you can print out. And then for all the different color codes, so in each area, so for example in the number 1 you've got chest pain, breathing difficulties, like your more acute, urgent emergency type. They've actually got color cards that you can have along with your wall chart. Those for the different conditions. So the idea is that this gives the reception staff or whoever's assisting the patient a series of activities or things that they can do to support the patient while we're waiting for, say, the ambulance to arrive, or even if it's just waiting for the GP to come into to the waiting room or whatever it is. Yeah. So that's another good one, which you can print out. The CEPA, the people who develop this, they can actually sell. They actually do sell the packs. So I think, I can't remember off the top of my head. Has anyone purchased it directly from them? I think they're about $70. Yeah, so they're around $70, $80, and it's already, the pack is prepared, and it comes with one of the wall charts. But all of it is available online. They're reviewing it, but I can send you the last version. And it's all in Word document, so you can still modify if you wanted to change the advice or things like this. Okay. All right. I want to move on to infection control. Actually, before that, I just wanted to double check what are some of the key conditions that we would consider urgent. So what are some of the key things that we'd be looking for? Chest pain is a big one, which can be, it can mean what? It could be a heart attack, which is why we worry, but it could also be indigestion. So that's why you can't, it's, yeah, or a muscle, yeah, musculoskeletal issue. But chest pain is one of the ones where we would, if you're a reception staff and you are passing the call to nursing staff, so if you have nursing staff or doctors who are available to take the call and make the decision, then that would be a prime example where you do that. What else would you be looking out for? Respiratory. Yeah, respiratory, so breathing difficulties, swelling, yeah, if someone's got swelling of the throat, yeah, closing of the throat. Bleeding, yes. Excessive bleeding, yes. What else? Weakness on one side. Why? Because what could that mean? Stroke. With stroke is one of the big, what's the acronym that we use? FAST, which stands for F for face, yeah, because we get usually a drooping sometimes at one side. A, it's arms, yeah. So it'll often, because one side will often shut down, they'll have the drooping of the face and they'll lose strength or completely lose ability of moving one side, yeah. S is for speech. Obviously, if you have half of your face is down, your speech is going to be slurred. Sometimes you'll be able to tell over the phone, yeah? How can you tell if someone's having difficulty breathing just from over the phone? Difficulty talking. Struggling to get the words out, yeah? So that's some of the things that, oh wait, what's going on here, yeah? And what's the T in fast? Time, just act fast. That's one of those ones that we don't necessarily want them to be coming to the medical center because there's not that much that we can do for them here. We want them to get emergency access as soon as possible. Yeah? Any questions? You happy to move on? Okay, let's get into infection control. How many of you have this book in your clinics? Yeah, 2, 3, 4, 5. Yeah. So these are this is again from the RSCGP. These are the infection control standards. So they're separate to your accreditation standards, but the accreditation standards make reference to this when it comes to the infection control areas. So these are your infection control standards for office-based practice. Office-based practice meaning we're not a hospital, yeah? We're a general practice. A lot of times people will come from hospitals, especially like nursing staff will come from hospitals going, this is not how we disinfect things in a hospital. It's like, that's fine, this is not a hospital setting. These are the guidelines that we follow. They're actually it's quite a user-friendly publication. So for example, with all of the things around sterilization, it's got pictures and it walks you through all the different steps. It's not free though. This publication, unfortunately, you can't access online. Everything else you can access online for free, not this one. This one you need to purchase. And I think it's over $100, I think, off the top of my head, 100 and a bit. But it's a fantastic resource for infection control in our clinics. So let's get into this. So what is infection control? What is it? Preventing the spread of disease, yeah. Preventing the passing of bugs from one person to another. So it can be from staff to staff, or from patients to staff, or from staff to patients. Yeah. So what are some of the key things that how do we prevent the spread of bugs between staff? So hand washing, yeah. What are we using for hand wash? Because it's incredibly inconvenient to have to go, hi, Mrs. Smith, or here's a pen, and then now I have to, excuse me, I have to go to the bathroom and wash my hands, and I'll be right back.
Gel.
Hand gels are just as effective, unless, when do we not use the hand gel? If your hands are visibly soiled. So if you actually if you can see the gunk and dirt in them, you need to go and wash them. Yeah? Good. What else can we do in terms of preventing the infection of staff? So as a staff member, what can you do to prevent yourself from getting?
Wiping the phones.
Yeah, wiping the common surfaces.
Protective gear.
Protective equipment like
Masks.
masks. What are some of the opportunities where we would definitely want to make sure that we're wearing goggles?
Cleaning spills.
If you're cleaning spills, if you're doing sterilization and you're doing the actual cleaning of the instruments, very easy for things to splash. Do all of us have needle stick injury, what to do signs, in the treatment rooms? Not somewhere hidden where you go, where was it again? Yeah, because you want to be able to access it quite quickly. Yeah, good. What else? We talked about staff immunization, staff training. Again, I'll show you the staff training sheets. So all new staff, and even old staff, and by old I don't mean the age old, as in they've been in the practice for a long time. All staff should not only just be trained, but should be refreshed on infection control and triage, which is why what I suggest is with those staff training sheets that I'm going to show you, they cover a series of topics. So what I often say is let's just cover one every quarter or so, or one every couple of months as part of our staff meetings that we're all having, yes, on a regular basis. Good? Yes? Good. All right, what can we do to prevent the spread of bugs amongst patients?
We can segregate them if we find they're
Yes,
really...
so we can actually divide them, separate them if they're like what?
If you think you've got chicken pox, or
If you
even
think someone's
flu
got flu or chicken pox, how could you separate them though?
another room.
Another room, yeah. So potentially we could put them in a treatment room or a separate consulting room. Mask, yeah. When we had the pandemic, there were also people being instructed to wait in the car or wait outside, and then we'd ring them when the GP was ready to see them, so that they're not sitting in the waiting room coughing and just spreading bugs everywhere. Yeah. Any other things that you've done in your clinics?
Chairs 1 meter apart.
Chairs 1 meter apart, yeah. Often it's easier said than done if you don't have the.
That's right.
Yeah. Gonna be tricky, yeah. And the cleaning. So we've addressed all these things. Now, one of the common questions that I get is with the cleaning. What do we use for cleaning of surfaces? So there's Clinidet, Sonidet. So there's disinfectants and then there's detergents, clinical detergents. Yeah. What do we use, or what's recommended to use in general practice? Disinfectant or detergent? Clinical detergent. So your Clinidet, Sonidet is a clinical detergent. Disinfectants are the ones that kill. Detergents clean. Your detergent won't kill the bacteria and the bugs, it'll just remove them. Okay? So the thing with disinfectants is often that for disinfectants to actually work, they need contact with the surface, sometimes for up to 10 minutes. Yeah? It's not viable in general practice, and it's actually not really necessary. So we use disinfectants in hospitals, but in general practice, clinical detergents is what we use. Keeping in mind that the detergent doesn't kill, it only cleans. What do we need to then make sure? So if we've got a surface and we want to make sure that we disinfect that surface, we use our spray. The spray gets onto the surface, it picks up the bugs, so it holds them suspended on the solution. And then, what do? We wipe it off with what? With a low or no lint paper towel, yeah. And what do we have to then make sure of? That we're leaving that surface
dry.
Dry, because wherever's wet there's still bugs in there. It doesn't matter how long you leave it there, it's not going to kill them. We need to make sure that it's completely dry, and now the bugs are in our tissue. So this is contaminated, and it will continue to be contaminated. So what do we want to make sure we do with it? Yeah. It doesn't have to be hazardous waste, but it needs to be disposed safely and securely. Good. Any questions around that? No? All good? Yes?
I'm just thinking, what about handles and
Yeah.
like that in general
Yep.
practice?
So one of the things that often happens, so the question was, what about handles? Yeah. Any of the main surfaces should be cleaned with a clinical detergent, and it often will be your solution that you'll prepare. How frequently do we prepare that solution? Every day. So it should be prepared fresh every day at the start of the day. All the surfaces should have a clean at least once during the day. Yeah? Ideally, it should be twice. So one in the middle of the day and one at the end of the day, regardless of whether or not you have cleaning staff coming later on and cleaning the other surfaces. Because 9 times out of 10, the cleaning staff will just, they'll sweep and mop and they'll just tidy up, but they won't necessarily clean the surfaces. Yeah, and you have no real way of knowing. Yeah? So with, it's a good idea to have a cleaning roster, at least for the middle of the day, where you know that, yeah, I'm going to make sure that I clean the handles and the main surfaces. So the bench stops. What are you doing with kids' toys?
Sometimes we soak them.
Soak them. So what kind of toys would we prefer to have?
Plastic
Yeah,
stuff.
something that we can actually disinfect. Something that's a fabric or plush toy. Bad news. Bad news. Yeah, we can't really disinfect it. Okay, any other questions around that? No? All right, we're almost really there. So these are the staff training sheets that I was telling you about. You can actually download them from the practicenursing.info website, but you can also send me an email and I'll shoot them over to you. So the way that the staff training sheets work, as I mentioned, they cover different areas. So it's covering, there's actually an immunization consent or refusal form as part of it. There's also an induction checklist that you can use to train new staff, because what I often do is I will print them out and put them in a little thing like this. And so every new staff, I pull all my sheets and go through all the training, tick through, yep, we've taught them and inducted them on all these different things. It's got triage education, cleaning and disinfecting surgery surfaces, cleaning spills, disposable instruments, if you have disposable instruments. There's actually also a sterilizing instruments, which again, it is very general, like generic, because it'll depend on the actual, what do you press on the sterilizer, will depend on what brand sterilizer you actually have. But it's more the generic steps of cleaning, the pre-cleaning, packaging, and then checking. Disposable instruments, fridge temperature records. So that's what some of you would have been if you came to the cold chain talk. You would have had the fridge temperature training. Interpreter services, safe disposal of sharps, and infection control. So the way they work, as I said, at the bottom of the sheets, they've actually got a section where the staff can sign and acknowledge that, yep, on this date they've received training on this and that they're comfortable now, they feel competent in this area. That the staff can keep a copy of that, so that can be part of their professional development, and you can keep a copy as evidence of in-house training. Good. And we've talked about then the resources. So the key ones being the RCGP Standards for General Practice, 4th edition, which we can access online. RCGP Infection Control Standards for Office-Based Practice, which is this book, which we can't really access online. We can download online. Sorry, we can download the order form to purchase, but they only have I couldn't even find the image of the book. Like, you can only find the description and the order form to buy. And it's a great book, so I don't know why they haven't promoted it more. Our website, obviously bml.org.au. You can, I've got links there to under the accreditation section, to the practice, the policy and procedure template. So if you don't have a policy, which I doubt, around infection control or triage, if you're accredited, you would. You can download them there if you just wanted to review it, because they get updated on a fairly regular basis. So if your manual's from 5-10 years ago, it's probably a good idea to get in there. That's what I was talking about, the CPA. There's a triage support guide. At the moment, if you go in there, it says it's under review. They will update it shortly. But if you send me an email, I can send you the last file if you don't already have a triage form with you. And the staff training sheets, where you can download from the practicenursing.info website, or again, you can just send me an email and I'll get that through to you. And cute. Any questions?
Is there any time left to see patients?
Is there ever any time left to see patients? The answer is no. That's why the best practice is the one that doesn't have any patients. All the policies and procedures are in place. All our recalls are in order. Yeah,
Everything's perfect.
that's the best hospitals and the best clinics are the ones without patients. And teachers will say the best schools are the ones without students. Yeah. Yeah. So that's it. You've got some evaluation forms there that you can fill out. Thank you very much for coming in over your lunch break. And yeah, you've got all our details, so feel free to get in touch if you need anything.
Thank
you very much.
Magali.
Thank you.
Much appreciated.
You're welcome.